Hello, I'm delighted to welcome you to the Gustave Roussy chemotherapy course of 2025. The chemotherapy course taking place has the advantage of presenting all cancers. We will have a special focus on pancreatic cancer, and I am delighted to invite Dr. Alice Boilev for this presentation. Pancreatic cancer remains a cancer with a poor prognosis and a bad reputation, but precisely we will see that despite this bad reputation, there are a number of therapeutic advancements. So first, a few words that are not words. We will start a little poorly, which are not extremely favorable words. It is the problem of the epidemiology of this cancer, which occurs more and more often, and increasingly in young subjects, it must be said.
Absolutely. When we look at both the global numbers and the French numbers, ultimately we notice an increase in pancreatic cancer, this deadly cancer. It is currently the 4th to 5th cause of cancer mortality, and it is estimated that by 2030 to 2040, it will represent the 2nd cause of cancer mortality. So ultimately, it is already a public health issue. Just with these figures, it is one of the cancers that is increasing, and we can move to the next slide. We see it in France. We are at more than 300%. The figures are frightening, rightly so, and ultimately that's why we need therapeutic innovation. Another concern of ours is the increase in cases among young people, and especially when we say young, well, in digestive oncology, it's under 50 years old.
All the same, given the prognosis of this cancer, the fact that there are patients aged 40 to 45, as we are starting to see now, who are affected by this cancer is a real problem.
It's a real problem. It's an issue both because in fact, the mortality rate is still very high for now, with a median survival of around 1 year. When at the metastatic stage, these are patients with specific issues, fertility, tolerance of treatments, work, which we didn't necessarily use to manage in digestive oncology because the median age of diagnosis is rather around 65 to 70 years. And the other reason that worries us is that we don't know why there is such a rejuvenation. And when we see 35-year-old patients in consultation with metastatic pancreatic cancer, it's clearly patients we didn't have even 10 to 15 years ago.
Precisely, that was one of my questions and a bit of a comment. Does the fact that he is young change things? The presentation of the disease, meaning do we have more metastatic cases in young people, fewer metastatic cases? We know that someone young might worry a little less when they have symptoms. So is there a kind of specific profile of young patients in the presentation of the disease?
In the presentation of the illness, we did it by looking at patients treated at Gustave II, and what we actually feel is that they might be a little more severe, a bit more metastatic diseases at diagnosis, sometimes slightly more aggressive diseases. Then we don't feel that it's ultimately such a different disease. It's a disease that is probably diagnosed a little later because typically the symptoms of lingering abdominal pain in someone who is 35 or 40 years old don't necessarily prompt an immediate scan. But despite everything, the disease as such, when we look at all that is biological and molecular
Yes, it was a question I was going to ask about molecular biology. We know that most pancreatic cancers are metastatic. In young
maybe
subjects,
just a little less KRAS mutation, but ultimately when we look at the different cohorts that have been published, whether ours, Vall d'Hebron in Barcelona or MSK in the United States, the figures contradict each other a little bit, maybe a little less KRAS mutation, but in any case, there's nothing that stands out to make us say that it's a different disease. Actually, it feels like it's the same disease, just a little younger.
And then the cause?
That's a very good question, and this slide raises one of the questions. I'm not saying it's one of the only reasons. Ultimately, even just the risk factors for pancreatic cancer are not very well known. There are some type 2 diabetes, tobacco, BRCA2 mutations, BRCA1, chronic pancreatitis, etc. But ultimately, these different known factors, they explain maybe 20% of pancreatic cancers. And for 80% of our patients, no, we won't be able to tell them why they have cancer because in fact, we can't find any specific risk factor, and that's really from consultation experience. But the patients we see who are young with pancreatic cancer who come to see us, they are a normal weight. They follow the sports diet,
sometimes
a classic Western diet, but not
runners.
Specifically junk food, not necessarily tobacco, alcohol, etc. And actually, we do not know why these patients have pancreatic cancer at their age are.
Still, in terms of epidemiology, don't we have the impression that this increase, therefore, in slightly younger patients, what we call early onset? In English, it appears more in Western or Westernized societies. Now, this term is complex to use because with so many emerging countries, it seems there is still something related to that.
From an epidemiological perspective, it seems that this increase is mainly in Europe and the United States, maybe a little less in Asia, a bit less in South America or Africa. So the risk factors we suspect are going to be risk factors related to our societies. So there's everything that is processed products, microplastics, food packaging, pesticides, air pollution, etc., which are ultimately prevalent in the current society in which we live in France, in the United States, for example. And to show you one of the leads we have is on the use of pesticides. This is a study that was presented at the GAIFOD last year by Dr. Bruegel on the correlation between the use of pesticides in France on the occurrence of pancreatic cancers at the national level. And we found that there was an increased risk associated with the use of certain substances, such as glyphosate, for example. The general public knows that. So obviously it's a correlation. We are dealing with epidemiological studies.
Are complex.
There are confounding factors. There is another study they did where they went to measure the pesticides in visceral fat. Finally, visceral fat is the fat that surrounds the digestive organs, and it is considered that it will store the pesticides we have been exposed to during our lives. And by comparing cases of patients with pancreatic cancer with healthy subjects, what's a bit concerning is that we'll find pesticides almost everywhere, ultimately, but some that will be on microplastics, etc. But we will find some in greater quantities and some specific ones in patients with pancreatic cancer. So obviously more research is needed on this, but it's one of the leads. There are others, for example, the microbiota, which could be altered by antibiotic use in childhood. And these are subjects we are specifically interested in within the team, precisely to try to understand why is there such an increase, because if we understand why there is an increase, we might be able to propose corrective measures or at least try to halt the epidemic, because we're almost talking about an epidemic, and also potentially propose screening for certain people who might be at higher risk than others.
Yes, as part of
in the context of interceptions, for example.
On prevention here. The prevention of cancer occurring before it is present. So if we focus a little on treatments, has the treatment of pancreatic cancer changed brilliantly? Are you going to present us with an absolutely fantastic therapeutic
Based
innovation?
on the current recommendations, unfortunately, I stick with the good old chemotherapy drugs. We see it here for treatments at the localized or locally advanced stages. At the localized stage, the treatment remains surgery followed by adjuvant chemotherapy with FOLFIRINOX. Modified FOLFIRINOX, as shown in the study by Thierry Conroy. At the locally advanced stage, we've had the results. It's still a relatively recent innovation because the results of the NEOPON study that you conducted were recently presented at ESMO 2022. Nevertheless, it's still FOLFIRINOX, so we're using the same chemotherapy molecules that were quote-unquote recycling.
A small point perhaps for the local ones, those that are accessible for a resection. There was a trend of the neoadjuvant where we thought that the easily resectable ones, we might be able to increase their survival even more by doing FOLFIRINOX not afterward, because we know that doing FOLFIRINOX after a pancreatic duodenectomy, it's not always easy because there are post-operative courses that aren't always straightforward. And for now, this neoadjuvant for the easily resectable, it's something that hasn't proven its effectiveness at all.
For now, in fact, despite a concept, let's say, that is interesting, the different studies, in fact, are negative. So there is no modification of the standards. It's like, for example, with radiotherapy. And we recently had, for the borderline cases, the results of the PANDA study at the European Society for Medical Oncology, presented by Dr. Lambert from Nancy. Ultimately negative studies again. So doing chemotherapy plus radiotherapy plus surgery does not benefit borderlines.
For borderline cases, we do neoadjuvant chemotherapy. and it's
We are doing
FOLFIRINOX.
chemotherapy, yeah.
But on the other hand, there is no benefit in doing radiotherapy. We must then proceed to surgery.
So just at this stage, we'll discuss it in the last part, but at the adjuvant stage, the new things we might have are still therapeutic vaccines, and we'll talk about that in the last part, so that might still change
so there it is,
some perspectives.
It's a teaser of perspectives.
Exactly.
Now for the metastatic.
For metastatic cases, we return to our usual FOLFIRINOX, and there we finally have studies that have not been compared to each other. Here I present to you the three main phase 3 studies that are positive in the case of pancreatic cancer. The first, Cocorico, yet another French
and
study,
again,
FOLFIRINOX versus gemcitabine, again Thierry Conroy in 2011. It's a standard that is still a standard and
Thierry
quite dated.
Conrad,
We would like this standard to change. We don't really like standards that last long, and as you can see, we have progression-free survival around 6 months and overall survival around 11 months. Another positive study, and thus a bit more conducted in the United States probably, although they revisit it, gemcitabine and nab-paclitaxel, which is also a standard, 5 months not compared, not 2 to 2. So for us, in our practice, it's true that FOLFIRINOX is a bit more toxic for patients who are a bit less fit.
For the patients
we will
who
use
are the fittest,
gemcitabine,
and
nab-paclitaxel a bit more easily. And the latest study, NALIRIFOX, in the end, is a FOLFIRINOX.
It is still a real innovation.
Real innovation, it's FOLFIRINOX, and we replaced irinotecan with NALIRI, which is liposomal irinotecan. Overall, it's still a molecule that resembles irinotecan. As you can see, the overall survival rates in the NALIRIFOX study are 11.11 months. It is done, for example, in the United States. Here in France, we do not have the possibility to do it. Would it gain anything? I am not necessarily sure. In any case, it's a true phase 3 study, properly conducted, which is positive and is compared to gem and nab-paclitaxel.
This is the whole interest and specificity.
There you go.
In this case, NALIRIFOX is a 3-drug chemotherapy compared to gemcitabine combined with nab-paclitaxel. A network meta-analysis has thus recommended for fit patients, as previously mentioned, to opt for a 3-drug chemotherapy.
And so currently, ultimately, it goes back to what I said. In the first line, we more or less know what we're doing. In the second line as well, overall, we will resume either a gemcitabine-based regimen if FOLFIRINOX was given, or a FOLFOX or FOLFIRINOX-based regimen if gemcitabine was used. And in the third line, we don't know what we're doing. We don't know what to give, or we have no standard. It's difficult to leave patients without treatment when they are fit. We will tend to do, for example, either rechallenge with FOLFOX if the patient had gemcitabine in the second line, possibly doing carboplatin with 5-FU in patients who are still suffering from neuropathy.
It is true that when we resumed our experience with the third line, it is not...
in the third line is not very high.
We really need to be of a bad kind.
Yeah, and by the way, from not very high, and progression-free survivals do not stand out regardless of the treatment we use, but we have innovations.
So let's get to the innovations. So what are these famous innovations?
So the innovations, one of the first, obviously there are several avenues, but it will be precision medicine. Genomic in any case, precision medicine. There are several possibilities. New therapeutic classes are emerging to target the disease of vaccines as part of precision medicine, play a key role at the localized stage. Tumor samples can be collected during surgery. We will analyze it to specifically identify the driver mutations of these tumors and make specific vaccines for the patients to reduce the recurrence rate. Therapeutic vaccines are one example. We also have all the new drugs.
They are currently being tested. We have a study underway to authorize their production, and they are administered to patients during surgery.
There are new molecules, the ADCs, the antibody-drug conjugates, such as trastuzumab deruxtecan, bispecific antibodies, tyrosine kinase inhibitors, and finally pancreatic cancer, which is still quite minimally driven by molecular drivers. It's KRAS.
There aren't exactly thousands of actionable anomalies.
There aren't thousands. Ultimately, the main one we have is KRAS. So if we place ourselves now in 2025, there are trials. But on this slide, we see that the patients with KRAS mutation, ultimately, we find 15 to 20% actionable anomalies. There are quite few. And for those patients, it is KRAS that needs to be targeted. The other patients are somewhat more interesting in terms of diversity of targetable anomalies, with more fusions found in these patients. And so there is clearly an interest in pursuing precision medicine and targeting these KRAS wild-type patients.
But what are wild-type KRAS? It's about 10% of the patients. So basically, we can say that for 10% of the patients, we really need to investigate. And then sometimes, even in a significant number of cases, approximately 30%, something like that, we find an actionable anomaly and we try to find the trial or the drug that allows it. And for the others, we wait for the anti-KRA. That's clear.
We are waiting for anti-KRAS therapies, and now things are really starting to accelerate.
They are really... So we shouldn't say that because unfortunately we don't have them directly available at the moment, but it will come by 2025 as part of therapeutic trials.
It should happen around 2025. There are different types, specific anti-KRAS, which target, for example, the KRAS G12D mutation, and pan-KRAS, which can target all KRAS mutations. We can dream that in about 10 years we won't know what to do because we'll have so many. Just on the previous slide, there are also in molecules target of interest, the expression of Claudin 18. That's about 30% of patients with pancreatic cancer.
We are waiting for
the results that we should have.
With hemicyclamine, paclitaxel, more or less, we should have around 2025.
By this year 2025, the MTAP deletion is also basically the genetic, and in any case, molecular landscape is expanding in pancreatic cancers, and much is expected from the anti-KRAS
Yes, we're not at the lung stage, but still there are small,
there you go, it's moving.
And then we need the anti-KRAS, that's for sure. And then after, there are the organoids.
Organoids, then
they are
one of my favorite topics.
The subject of your science thesis. You worked in Fanny Jolin's lab on it here, so a little word on
a very brief word
organoids.
On organoids. Organoids, what are they? Actually, they are sorts of tumor avatars. They are mini tumors that we cultivate in the laboratory. In summary, we collect cancer cells from a given patient thanks to a biopsy, a tumor biopsy. We culture the cells in the laboratory. We obviously check that they match the tumor they originate from. We verify that it is present in the organoid. And what is interesting is that there are different studies that have shown a good correlation between the sensitivity of the organoid to the medication and the patient's response. Overall, this would allow the use of organoids as a test and finally conduct a sort of mini therapeutic trial for a given tumor in the laboratory. A sort of antibiogram, a chemiogram in this case, which would allow us to say which medications. That's what we like in the clinic. It's when I start chemotherapy with FOLFIRINOX, ultimately I don't have a marker that will let me say whether FOLFIRINOX will be effective for this patient or not. And the other issue is the or not, because there are patients who have chemotherapy that is effective and toxic.
Our hope in this area is the signatures.
We collect a tumor sample, then perform a transcriptomic analysis, which means an RNA sequencing analysis. Through this, we can predict whether it is better to administer the patient regimen based on gemcitabine or a regimen based on FOLFIRINOX. And these are the final results of the study we conducted at Gustave Roussy, which showed that we were able to successfully create organoids in about 2/3 of the patients. With good specificity and sensitivity, obviously it's a study on a small number of refractory metastatic patients, and the results require further studies to be generalized.
I think it's time to wrap up now. I hope we have shown you that pancreatic cancer remains a cancer with a grim prognosis. Indeed, it is on the rise indeed, but we are now seeing therapeutic advances, particularly in the field of drugs, with the anti-KRAS we talked about, also with everything that genomic medicine will bring us to try to better characterize patients at the molecular level and possibly truly use personalized medicine. What we showed with the organoids, which will allow perhaps determine specific sensitivities, and then many other studies also in the field of the microbiome, in the field of macrophages, a number of studies in which teams at Gustave are also extremely involved. Pancreatic cancer remains for us truly a challenge, and we are investing a lot at all levels to try to move things forward. Thank you for listening. This debate was recorded as part of the chemotherapy courses, and you can find all the recorded chemotherapy courses on the Gustave Roussy website.